Thank you. So we're here to talk about collaboration between Department of Homeless Services, the Manhattan Outreach Consortium, and Bellevue Hospital's ER. And I wanted to start talking about how DHS comes to this project. Some people may recognize this poster from the subways and may know it as our redesigned street outreach programs. And when we redesigned the street outreach programs, it was in this vein to try to take the services that we are and not serve everyone, but to serve the most chronic people with 4 to 5 times the services that we were able to give them before. So to really prioritize the people that are having the most difficulty resolving their homelessness. And although we define chronically homeless clients as 9 months out of the last 24 on the street, they were finding that our average is 7 years. The program is designed to wrap around them and to follow them all the way into housing and do what it takes to make them supported there in housing, to make sure that we're not closing out their case until they're fully integrated into their community. So this project began, this redesign, in 2007, and it combined the money that had been spent on street outreach from the Department of Health and DHS. You can see that we had some baseline numbers and a target for 2010 that we were looking towards as part of this larger national project of reducing homelessness. And so that's how we distributed our resources. And it's been incredibly successful on the front of housing these chronically street homeless clients. The housing retention, as I highlight there, is over 90%. And I think that part of it is that our core metric is not contacts, it's housing. These targeted population. So, and this is taken from a CUCS paper, but that the metric is meaningful, measurable, and manageable, and that everyone knows what the big idea is. You know, if we're all working on contracts, we know that you've got 50 different metrics that you're using to judge what you're doing. This becomes a very clear bottom line. And part of this is that the redesigned contract holds 25% of the money aside that can only be earned when you house long-term street homeless clients. At first it was a smaller amount, but then it became a larger amount as the contracts progressed. And each year, this is the first 3 years of the contract, we saw improvements in housing placements. And I think this really does show that there's a learning curve that we had about how to do this and how to do this well. And this is continued to this day. And so this pay for performance feature from a government perspective, I feel like is incredibly powerful. And that's not to say that people are in it for the money. It's to say that what happens is, as a government entity, and we have these very complex structures, we send clear signals as to what the goal is of this project. And that helps to shift some risk to the contractor, and for the contractor to know directly what it is we really care about. So now I'm saying why we came to this project with Bellevue. This is not this year's survey, but last year's survey results. And we could kind of see, as the contract was progressing, that our hope counts weren't dropping to the levels that we had wanted them to get to. We were making good progress. Look at the Bronx, it was very dramatic. Drops in the amount of street homeless people, but we knew that we were missing people, the tactics that we had designed to try to find all these really long-term homeless people. The net was missing some people. So we, another part of this project is not just to reduce the amount of people living on the street, but then the other hand was to prevent death. And It's a very compelling reason. It's a lot of the reason why we do our work. It's try to improve people's lives, but to prevent death is very tangible improvement in someone's life. In New York, in 2005, there was this Local Law 63. And Local Law 63 requires the government and various agencies, including DHS, to track every homeless death and to do a deep dive into what were the conditions of their death. And so that we can learn and redesign and figure out what's going on. And from 2005 to 2010, there's this 841 homeless deaths. Over half of them are on the street, chronically street homeless clients, people that weren't successfully engaging in the shelter system. And so that's really comes to us, and we think, how do we take this information and inform us in how to work better? And then also, too, there was also clear signals that people had just been in medical care, that they had bracelets on, they had prescriptions on them. It's not like we went and surveyed all the hospitals to see if they had just had medical care. It was on their body that we could tell from medical examiner reports that they'd just been in the hospital. And so it's with that we started to reach out to the hospital emergency rooms. Also during the Hope Counts, the hospital emergency rooms used to call us in and say how many people were waiting in their lobbies that were homeless. They assumed to be chronic, long-term homeless. And so we had attempted to engage, and DHS were a very difficult organization to engage with. The hospitals are also a very difficult organization to engage with. It's a big hierarchy. In our public hospitals, the HHC hospitals are even a bigger hierarchy of lots of different bosses, lots of different departments, people, very hard to penetrate and to really talk. So the Manhattan Outreach Consortium and DHS, we had tried to talk to a lot of different ERs and try to see, like, how can we, hand off better? How can you tell us about clients better? And we'd had one meeting with Bellevue with their residents, and they'd written down a little just informal list of 10 people that are there all the time. And one of these people ended up dying, and we found him in the homeless death report, and it was in January 2009, and he died of hypothermia, of the cold, and he was 32. He'd had 429 emergency room visits, 429. I mean, that he's in the hospital so much that we were not seeing him on the street. When we trolled through all of our 311 calls, all of our engagements, we'd only seen him like once or twice, very briefly. And this is someone who, we're looking for. Like, we're highly motivated to find this guy. And we could not find him because he's in the hospital that much. And the hospital was not equipped to find us. They didn't know the number to call. They didn't know that we would be so motivated to find him. So this was a wake-up call, not just to us, but also to Bellevue. And there was, this was what became a starting point for this project to work together. Also, I want to say that there's a management practice, training practice that they have in New York City government where they swap high-level managers. So it just so happened around this time that a high-level manager from DHS was swapped with someone at HHC. So there was some high-level vehicle we had to really talk to the heights of HHC about why this is important, and it helped to lay the groundwork so that we could start a collaboration together. So with that, I'm going to hand it over to Joe. Okay. Oh, maybe I'll do this one last slide. Sorry. So we did come up with a pilot together, and what we decided to do was to target the 20 top users of ED services. And cut further, it was for homeless clients that had one admission for alcohol use. And This graph, it's not to scale, but just to say, you know, there's a lot of clients in shelter. There's a big group of people that's on the street. This is a smaller group that we're falling through. We siphoned out people that we were already working with from the outreach, or that we were going to exclude people that were already engaged in a shelter. We have not found a client that fit that description just yet. And so it's this group of clients that we've been calling chronic public inebriant or hospital homeless. The names are not really accurate. We're still learning this population, but this small group of clients is who we were going to wrap around and see what we could do to collaborate together. And Joe's going to explain how we did that.